All right, so we start from here. We'll pick it up from here, okay? So let me make some few clarification here. Then we pick it up from autonomic dysreflexia. So concerning the chest tube, what we all spoke about was that whenever you have any question, like the trach relent, whenever you have any question about chest tube that has not been connected to a suction, whether it's suction wall or the suction, whichever. Okay. So if the question doesn't mention anything like suction in the trach was, take it to be underwater seal drainage or a water seal chamber. And for that one, the normal that we expect is that we have an intermittent tidalling or bubbling. The tidalling shouldn't be continuous, or the bubbling shouldn't be continuous. It should be intermittent. So intermittent, as in when the patient breathes in and breathes out, I mean, you should have it bubbling, okay, intermittently. But with a connection that has been connected to a suction, whether a suction or a suction wall or whichever, as soon as you see a suction associated with the question, then you should think that a continuous bubbling is normal in this case. And for that matter, it does not need any intervention. Okay, so we expect a continuous suctioning, a continuous bubbling in a water seal chamber that has been connected to a suction. But one that has not been connected to a suction, you should see it bubbling, continuous bubbling in a water seal chamber which has not been connected to a suction, then that is wrong. It means something is happening. There's a leakage somewhere. So we spoke about that part. Then I think this was where I wanted to make some things clear. Okay. So we have two ways. I was trying to explain certain things in a rush at the end of last week's lecture, but let me try and make it simple here so that we understand. I was trying to create something. Please, these are just sketches I'm making, okay? So we have these two round figures as almost round, or should I say lungs, okay? Then we have, for every lung, you have a visceral part and a parietal part, especially with the coverings. Okay. So these are actually the lungs. Then you have the pleural space. Okay. Now, whenever you put in the chest tube, we assume it finds itself in the pleural space. Okay. So let's say something like this. So what we are saying over here is that really pay attention and see what for us. Okay, so please take this extension as a chest tube connection, okay, with your, I'm just making a sketch here. So something like this. Then this is your water with your tube inside the water. So what we want to say is here, is that under normal circumstance, okay, or under normal respiration, This is what happens in the pleural space. This is the pleural space we are talking about. There is a negative pressure, okay? There is a negative pressure. Remember, your lungs are connected to your bronchus, trachea, then it goes up, okay? That's the normal anatomy. But over here, maybe you've been indicated to have a chest tube to solve a particular issue. So you have this chest tube in the pleural space connected to a water seal chamber. Now, before you can understand, I'm sure by now we are all reading the question, or most of us have read the question so that we can relate. Or if not, maybe we can take it together, then maybe try and follow with what I'm trying to explain. You're saying a patient is receiving positive pressure mechanical ventilation and has a chest tube. When assessing the water seal chamber, what do you expect to find? So we had 4 options and the answer is supposed to be C, right? Now, so I'm explaining the reason for choosing C and what happens here so that when you get understanding, you can relate. So within a pleural space, naturally, there is a negative pressure, okay? And the negative pressure, remember when there's a negative pressure, it means you don't have, should I say, negative pressure is like something sucking something out, okay? A positive pressure is like you are pushing a pressure in or you are forcing some kind of air into a space. Okay, so the pressure within the pleural space is a negative pressure. And the negative pressure keeps the lungs opening. When the lungs expands, it is the pleural space that makes space for the expanded lung tissues so that it can accommodate any air which is coming from the upper part of the body. What I mean by that is through the nostrils, your pharynx, trachea, and finally into your lungs. So it is the space here, the pleural space, that allows for expansion, okay? So under normal circumstance, when you're breathing normal, fine, that one is under normal tidalling. I'll come to the positive pressure aspect. So under normal circumstance, you have negative pressure within the pleural spaces. Okay, and I've told you the importance of that negative pressure. It helps to expand the lungs and also contract. It helps generally in breathing. Okay, so what happens is that during this time, what happens is that because there is a suctioning pressure, something like a negative pressure in here within the pleural space, okay, it moves air, some kind of air, it displaces air through this thing that has been connected to the pleural space through the tube, then forces air into the chest tube, and finally will make the water in the chest tube rise. Okay, so that is during inspiration under normal breathing. I'm taking that part again because that's the tricky part. So follow my words carefully. When under normal circumstance, the pressure within the pleural space is negative pressure, and that makes it possible to force some air, okay, into the tube, then down here, which, just imagine pushing some air slightly into this water. It will make the water level here to rise a bit, okay, because you have something which is increasing the volume. Okay, the air will come in, then it will make the water level here to rise a bit. And that is during inhalation. Okay, and during exhalation, the water level will rather drop. So that is the normal physiology. And what happens when someone is having a chest tube and normal circumstance? Please, I hope that point is clear. I'm now coming to the positive pressure part. Okay. Now, when someone is receiving a
Oh, guys,
positive
your
pressure
co-host, please
ventilation,
mute them for us. They are whatever.
when someone is having a positive pressure
Sorry,
ventilation,
we're not getting it. Somebody's microphone is disturbing.
okay, let me come again. So with the normal physiology, like I explained, okay, we have a negative pressure already in here, the normal circumstance. So when you breathe in, it forces some air through the tube because the tube has been found in the pleural space. You give someone a chest tube, that is where normally the tube ends up. Okay. So that is what we are talking about. Didi, I hear.
Yes, sir.
So I am making you co-host there. When someone is disturbing, you can mute the person for me. Okay. When someone's microphone. All right. So under normal circumstance, you have negative pressure here. So when the person is, takes in air or during inhalation, the pressure pushes some air into the tube, which makes the water level in the water seal chamber rise. And during exhalation, that is my circumstance. So is the clear when the person is I mean, it has been stated in the question that the person is receiving a positive pressure ventilation or not. But for what I've explained is for a normal person, someone who is not receiving any positive pressure ventilation. Now, I am coming to this question itself. Those receiving positive pressure ventilation, if you're able to keep what I just said, then the trick to the whole thing, these things are like tricks. As soon as you grab them, they are similar in almost all cases.
The line was breaking when you said what you just said, please.
So what I was saying, or what I said, is that what I just explained, okay, is under normal circumstance. That is if you don't have a positive pressure or you are not under any positive pressure ventilation. Okay. That is what I said. So I said the most tricky part is always check your question well. If they are trying to just ask you what will the water be, whether it will rise or it will fall in someone who has a chest tube, then you go according to what I just explained, the phenomenon. But in the question, when the question mentions that the patient is receiving positive pressure mechanical ventilation, whilst having a chest tube, when they're asking like what will happen to the water levels in the chest tube and the rest, it is the opposite of all that we have discussed. So remember we said if someone is not receiving positive pressure ventilation, you have negative pressure in here in the within the pleural space, and that will create some form of pressure, okay, to push air into the chamber, which will make the water level in the water seal chamber rise during inspiration, and it will fall during expiration. So that's under normal circumstance. But when someone is receiving positive pressure ventilation, During inspiration, the water chamber will rather decrease. Okay. Then during expiration, the water level in the chamber will rather increase during expiration. So the trick I want to let you know is that take hold or, just grab the normal physiology. Then whenever you get a question that indicates that patient is on positive pressure mechanical ventilation, make it the opposite. Then that will be all for you to go. So that was my way to make it more simpler for you. Any question at this time? So you see, let's relate it to what we answered here. So this person is receiving positive pressure mechanical ventilation and has a chest tube. So when assessing the water seal chamber, what do you expect to find? So you see, if there wasn't any positive pressure mechanical ventilation, we know that the water in the chamber will increase during inspiration. Then this one could have been correct if the person was not on positive pressure mechanical ventilation. Okay, if the person was not on positive pressure mechanical ventilation, this one would have been correct. Because during inspiration, the water level in the chamber will increase. Okay. And it will decrease during expiration. But it is the opposite. So you can see that A is just opposite to C. When you are receiving a positive pressure mechanical ventilation, it should be the opposite. So that's why the answer is C. I think I've been clear enough, haven't I?
Okay, so boss, if I get it right, then it means the last time the question was about positive pressure mechanical ventilation. And then the answer has been A, which I remember most people chose A, right?
No, we even showed the answer. The answer was C. Yeah, we displayed the answer.
But I thought you just said that if the person is receiving a positive mechanical ventilation, the water level should decrease upon inspiration. That's for the negative one. When you are receiving the negative or a normal breath.
No, so when you add so you see in the normal one, in the normal state or order, during inspiration, please can you hear me?
Yes, please.
So in the normal order, without any positive pressure ventilation, during inspiration or inhalation, you should have the water level go up or rise in the chamber. Okay. So I want you to stick to that one so that it will be easier. Then it will fall during expiration. That's the normal. Then just make it opposite. As soon as you see this positive pressure ventilation, make it opposite.
All right. Thank you.
You're welcome. Any other question?
You know, at the other time, when the question came, one of our colleagues said we should take it like calipo. The one with the positive pressure ventilation, we should take it like the calipo. When you are drinking calipo, the time you are sucking, the pressure in the chamber will decrease. But when you are doing expiration, then the chamber in the calipo will increase. So we should take the calipo drink as that of the positive pressure ventilator, or when somebody needed to breathe.
No, that was for negative, madam.
No.
So we were using that one to explain the negative. Okay. So with the calipo experience, okay, or with the some of us don't know calipo. Let me say carton drinks, okay, those small carton drinks. Someone should note that for us. So with respect to the carton drinks, that one can go with positive pressure ventilation if only you can understand it that way. Okay. And you know, when you are breathing in, it is like you are sucking. Okay, you are sucking the drink from through the straw. And for that matter, the drink level in the curtain will go down. Okay, so if you can apply that one to positive pressure ventilation, if only, that is okay for you. But for those of you who are okay with how I explained it at first, then I think you are okay to go. Okay, so with the calipo one, that's what I would say. If you are, just taking the drink, as you suck it in, you have water, drink level in the curtain reduce. And should you push air into the curtain through the straw, you see that around that time, or at that time that you are just blowing air into the curtain through the straw, it will rise up to a certain level because you forced air in it. Okay, so that one is in line with positive pressure mechanical ventilation. But if that will confuse you the more, stick to the normal physiology. Then when you have positive pressure mechanical ventilation, go the opposite and you'll be safe. You'll get all your scores. Are we okay? So
Hello,
you can read
Bosima.
the rationale and see. Yes, sister.
Yeah. So I'm taking it as that means negative pressure mechanism goes with our normal breathing. And then positive pressure mechanism is opposite our normal breathing in the water cell chamber.
Please, our normal breathing is neither positive or negative. It's normal. When you say normal, it's normal.
No,
Okay.
as in when you breathe, when you inspire, the water cell chamber will increase. And then when you expire, it will decrease.
Yes.
Okay.
Yes, that's for the normal. Okay.
Yeah.
And it is opposite when someone is receiving positive pressure ventilation. Like we are giving PEEPs, we are giving like BiPAP, okay. Something like, let me say CPAP in this case, because CPAP is just one way. Any question? Okay. All right.
Hello.
Yes.
Yeah, just to be clear.
Okay.
You mean that like the direction of when you say you what is the direction of when it's a negative pressure, right? It goes into the water cell chamber, right?
Okay, so generally, I want to know the difference between negative and positive pressure.
Yeah.
Okay, so generally, when we say positive pressure, you are pushing in air into your lungs, okay, or something, a pressure that forces air into a space. So that is a positive pressure. Okay, and if you want to understand how negative pressure is in simple terms, it is like you are removing air from a space or a vacuum, or you are suctioning something out, like you're suctioning air out. So that's a negative pressure, like withdrawing.
Okay.
So if you understand it in that way, I think it's more helpful when it comes to respirology.
Okay.
Please, any other question?
No.
All right. So I think we are now good with the chest tubes. We've finalized everything. So let us start with autonomic dysreflexia. Let us see what we have here first. Neurogenic distributive shock and autonomic dysreflexia. Before we touch on this one fully, let me ask, we have different types of shocks, of which neurogenic shock is part. I like asking this question a lot. What makes neurogenic shock different from all the other types of shock? With
Okay.
respect to vital signs, heart rate, blood pressure, especially.
The
Okay.
bradycardia.
Neurogenic shock has bradycardia and hypotension.
Bradycardia and hypotension.
Hypotension.
Good. So what happens in terms of the heart rate and the blood pressure, like you've mentioned, what happens to them in septic shock? Hypovolemic shock. What happens to them?
Tachycardia and hypotension.
Okay.
Of it.
So you have tachycardia in this case, and you have hypotension. So with hypotension, in whichever case, you're going to get low blood pressures. But with the heart rate, you normally get them high in almost all the types of shocks, except for neurogenic shock. So that is a nice observation. Let's look at what we have here. Then after, we can look at what autonomic dysreflexia is in brief. So neurogenic shock, a distributive shock is vascular dilation with decreased venous returns to the heart due to loss of innervation from spine as after a spinal injury. So with the classic signs of neurogenic shock, you will see hypotension, bradycardia, like we just said, okay? And you have pink, dry skin because you are hypotensive, okay? Your tissues are not perfused well because of vasodilation. So it's the vasodilation which is going to cause the, it's one way of causing the shock. Then neurogenic shock occurs in cervical or higher thoracic injuries. Okay, so normally when someone gets an injury around this area, around your sixth thoracic vertebrae or higher, okay, from your thoracic, you go to think lumbar, right? Then your sacral, that is going down. But coming up, you have T6, T5, T4, you have the T1, then you move on to the cervical one. Okay. So when you have a cervical injury or a thoracic injury, so up to this point, normally, okay, from higher to this point, that is where neurogenic shock is likely to happen. And in this case, we call it autonomic dysreflexia. Okay. When this happens, we have okay, so what we've explained first is just neurogenic shock, where you have your blood pressures and everything coming down. But there are some cases, I think let me touch on that one on our fourth point here. Let's carry on with what we have here. Systolic blood pressure should remain at 80 millimeters of mercury or above in order to perfuse your kidneys. Then administration of fluids is a priority to ensure adequate kidney and organ perfusion. Now, so bladder and stool impaction are etiologies for autonomic dysreflexia. So one thing is, when you get a question, what we are discussing, how you can get it practical is this. When you get any question that tries to specify a part of injury involved, then they tell you that the patient has maybe a spinal injury or cervical injury, cervical injury or let's say a thoracic injury, and they pick it up from T6 or above. And if you are provided some vital signs and you have hypotension, it is just neurogenic shock. Okay, you have hypotension, you have bradycardia and all those things. Then what it means is that you just have neurogenic shock. And in any shock, your first priority is to, not in any shock, but in most shocks, is to give fluids, right? Okay, so okay, I don't know. Maybe let me ask right now. Or we should leave it for another time.
You can
We
ask
have
what?
anaphylactic shock, right? And it's likely for you to have higher heart rate and low blood pressures too in anaphylactic shock or anaphylaxis in this case. So when you get questions on this anaphylactic shock or anaphylaxis, what is your priority in this case?
I am epinephrine. Oh,
Yes. So epinephrine is your priority. Okay. Epinephrine is your topmost priority because when you try to tackle the hypotension, there'll still be ongoing hypotension, even in the process of correcting, because what is causing the anaphylaxis is still in there. So why don't we give something to reverse what is actually causing the whole issue, and after we manage symptomatically? So that is why when it comes to anaphylaxis or anaphylactic shock, giving epinephrine, some, like in some questions, you see something like EpiPen. So anything epi, okay, EpiPen or epinephrine, the same thing. That is what we're talking about. That becomes a priority over there. All right. All right. So with the option 6 here, sorry, option 4, I mean the fourth point we have here, that leads us to autonomic dysreflexia. So we are saying bladder and stool impaction etiologies for autonomic dysreflexia and occur with a higher level fracture at T6 or above, with a stimulation below the fracture. So autonomic dysreflexia is a medical emergency. Please take note of this. If you never knew or you didn't take note that it's an emergency, it's an emergency. Okay. So whenever you are giving prioritization questions, it's like when you are giving DKA. In diabetes, DKA is an emergency situation, and HONCS, okay, or hyperglycemic hyposmolar non-ketotic syndrome. You know, that one is more in type 2. With the DKA is more of type 1. Okay. So they are all emergencies. So when you are giving prioritization questions and you're supposed to compare and pick an answer, like one that you give priority to, take notes of the emergencies in the question, then try and compare. Okay, use all your prioritization skills, and by taking notes of this part I'm talking about too, so that you can sail through with your answer. All right. So we are saying autonomic dysreflexia is a medical emergency that presents with severe headache. So this is one point. Severe headache. You have hypertension. Okay, your blood pressure goes up. We have piloerection. What's another name for piloerection?
Goosebumps.
Goosebumps. Okay. Then we have diaphoresis or sweating, right? Heavy sweating. So you have these as some clinical signs. Okay, and we are saying it is seen weeks to years after the injury. All right. Now, if you have any question here, you can ask before I add up anything. Any question? No questioning. Okay. So we have nausea to nasal congestion. I'm just adding some of the signs and symptoms to the autonomic dysreflexia. Okay, you can have blurred vision. nausea, nasal congestion, the headache.
Victor,
Sometimes if it's
please.
explained as throat
I
pain.
don't know how you managed to come up here.
Hello? Is the person talking to us? Okay. But can you all hear me?
Yes, we can hear you.
Okay. All right. So, like I said, blood vision, though it is not here, but take note of it. Blood vision, nausea, nasal congestion. If they describe the headache as throbbing, take note of it. Bradycardia, I think that one we've said it. So over here, your blood pressure goes extremely high. Okay, extremely high. Then you can even have pallor and chills. Okay, pallor and chills too can be part. But generally, what do you think is most common causes of autonomic dysreflexia in people with these neurogenic shocks? What is the most common? We have different, types, okay, or let's say different sorts of causes. But which one do you think is the most common type?
Full bladder.
Full bladder. So there are two: full bladder or constipation, like like full
Fecal impaction.
fecal impaction. Okay, so those are the most common ones. Okay, those are the most common ones. When you find out and you find like you were able to find to check and see if a particular part is the cause, you rectify that first. Okay, because let's say you have a kinked urethral catheter. That means whichever urine that is being produced will never enter into the urine collection bag. All right. So that is going to mount pressure in there, and that can lead to autonomic dysreflexia. Okay. And when you have this fecal impaction too, that one too can also lead to that. All right. Now, my question is, what is the first thing to do when you suspect autonomic dysreflexia in a patient?
Okay, you raise the head of the bed.
So raise head end of the bed, okay? Raise head end of the bed. So when you see raise head end of the bed, that is fine. Let the person sit upright. You see, anything that brings the person's head up, no matter how they've written it. So that is your clue. Okay, that's your clue. No matter how they've written it, if anything they say end up bringing the person's head up, then that is your answer. You're going for it. All right. Apart from bladder distension and this fecal impaction, do we have other noxious stimuli that can cause or precipitate this autonomic dysreflexia? Who can mention some?
Patients lying on an uneven bed linen.
Patients lying on an uneven bed.
Linen. Bedsheet.
Leaning. Patients leaning on an uneven bed.
Patients
That's
lying
a cramped,
on a, that's
a
like a
cramped.
crumpled bed linen.
Come again?
I'm saying like the patient lying on like a crumpled bed linen, bed sheet.
Can that one cause autonomic dysreflexia?
Yeah, I heard that's one of the
Yeah,
manipulating
in
the
one of
bed.
the Q banks.
Yeah.
Okay.
What about tight
Okay.
clothing?
I
Yes,
haven't
that
seen
one
that one.
too.
Okay. Okay. So what I've seen, those ones, I haven't seen them personally before. Okay. So I'm not sure. Maybe we can all find out. But what I've seen is the ingrown toenails or fingernails. Have you seen that one before?
No. Also haven't seen that
Okay,
one
when
before.
ingrown toenails or fingernails, then if you have a kinked urinary catheter,
Yeah.
so that is what I've seen before. But to find out about what you just said, like crumpled sheet and what constrictive clothing, right? Okay. Please, if you have any question at this point, you can bring it out so that we continue. If you don't have any question, then I have some for you. All right. My first question. The nurse performs discharge teaching for a 34-year-old male patient with a thoracic spinal cord injury at level T2 from a construction accident. Which patient's statement indicates teaching about autonomic dysreflexia is successful? Who can help us answer this one?
Yeah. So I'll choose the option A because it said I'll perform self-catheterization at least 6 times per day. A short period of learning this whole autonomic dysreflexia tells us that when a patient has a king urinary catheter or when the bladder is full, it can trigger the onset of this autonomic dysreflexia. So a patient being able to understand that he will catheterize every at least 6 times per day means that he will be able to drain the urine out of the bladder to avoid this autonomic dysreflexia. Apart from that, the question 2 said a reflex erection may cause an unsafe drop. No, there wouldn't be a drop in blood pressure. The blood pressure will rather move high. He said, if I develop a severe headache, I'll lie down. No, he said, you should sit up or raise the head end of the bed. They said, I can avoid this problem by taking medications to prevent leg spasms. No, we don't, these medications do not solve this problem. What we have learned that fecal impaction or constipation and then full bladder is the main cause of this problem. So I'll go for it. Thank you.
Wow. Do we all agree with what he said?
Yes, we do.
Okay.
Please, I have a question.
Please.
You can ask your
Please,
question.
why is it spinal cord injury T2? I thought it's T6 and above in the question.
Okay, so what is T? The full meaning of T? Do you know
Is
it's an
thoracic?
abbreviation? Yeah, thoracic.
No.
And it's part of your spine. Okay. Your vertebrae. Your vertebral column, right? The bones that make up your spine or your vertebra, your backbone. You have the cervical vertebrae, thoracic. You have your lumbar sacral. Then it ends in the coccyx. Okay. Yes, and we have each of them their number. So we said autonomic dysreflexia normally occurs when you have injury right from T6 and above. You start counting from up, down. Okay, so from T6 and above, it means T2 is a candidate. Injury at T2 is a candidate for autonomic dysreflexia.
Oh, okay.
And,
I thought it rather goes up. I didn't know.
oh no. Okay, so when I start, you see, you start counting C1, C2, C3, okay, like your cervical vertebrae. You count, and when you end with the last one, you come to your thoracic. Okay, then it starts from T1, I mean, from up to down, that way.
Oh, okay, thank you.
You're welcome. Please, did someone had any question to ask? I heard multiple voices trying to ask some questions. All right, if we are all on the same page, then I think that is fine.
Hello, boss.
Yes, sister.
Please, I beg you. So from T7 downwards, what do you get? Like,
So
what's the
you can
effect?
have, you see, every part of your spine, should I say, a related complication that it's okay, especially your peripherals.
Is it the paraplegia,
So
those areas that the paraplegia and other conditions happen, like T6 and
good.
below? Okay.
Spine, yes, okay, especially with your lower spine. But sometimes it also depends on the um the extent of the injury. Sometimes it depends on the extent of the injury. So a lot of things come in play over here. Please, are we good to go?
Okay,
All right.
sir.
So our answer is A. Here. Explanation is what our brother said. Okay. I think we all
Hello,
agree with.
boss.
Yes.
Hello, boss.
Please, I can hear you. Can you hear me?
Okay, and please, when our brother was talking, he said, I think I heard he said, we don't use medication to treat the condition.
Oh, yeah,
So,
yeah. So I wanted to even mention that, please. We don't use it to prevent or to avoid, okay? But when blood pressure, you see, autonomic dysreflexia is the main, should I say, path to follow, okay, in order to not to get this condition is to prevent, or let's say to go away from all these noxious stimuli, okay, to happening. But with medications, sometimes upon raising the head of the bed higher, and after doing your things, you can still get blood pressure extremely high or abnormally high. And for that matter, you use antihypertensives to also bring it down. Okay. Otherwise you might cause maybe an irreversible complication. You know what happens when your blood pressure mounts up high, very high. You can have kidney injury as a complication, stroke. So you know what extreme hypertension can do to the body. So of course, yes. Thank you for drawing our attention to that. You use medications if possible. But that should not become your first option. Okay, your first medication should be your last in this case. But doesn't mean you can't use it. You can use it. So thanks for drawing our attention. Any other question or contribution? All right. Which intervention should the nurse perform first in the care of a patient with autonomic dysreflexia? In the acute care, this is like a bonus question to all of us, right? What are we choosing?
C.
What are we choosing?
C.
Okay. Please, I hope we all agree, right? This is very easy, so I won't waste time here unless you have a concern. Okay. So that's the right answer. You can quickly go through.
So I'm just wondering if the question was to be like, what would be the best action to take? I think should we go for the bladder catheterization, or we should still go for the first option, this one?
In acute cases, please, the best, most priority, most essential, whichever you get, is elevate the head of the bed. Okay. That will be your priority right now. That will be the best action to take right now. Okay. Because the blood pressures are there. They are highly up. Okay. Look at this one. This one is not a bad option. That is correct. Option B2 is correct. Okay. And option D2 is correct. And this is your last option. So ask yourself, has the question given you a clear enough that the cause of it is urinary or it's from bowel? Do you get the question? So
Yes.
with that, you can't choose, I mean, A or B. Please, have I answered you?
Yes, I'm glad. Thank you.
All right. So we have another one. A patient with spinal cord, remember this is an autonomic dysreflexia. A patient with T4 spinal cord injury experiences neurogenic shock as a result of central nervous system dysfunction. What would the nurse recognize as characteristics of this condition?
Please, what is SNS dysfunction? Is it the same as autonomic dysfunction or
Central
just
nervous system.
okay? SNS central. The central
Hey,
starts
sorry,
with C.
sympathetic, right? Hey, sorry. Hey, wait.
Sympathetic nervous system.
Sympathetic nervous system. Yeah. Sympathetic nervous system. I said central. Sorry. Sympathetic nervous system.
Please, the answer is B.
No, C.
What would the nurse recognize as characteristics of this condition? Characteristics of this condition. So what makes it more neurogenic?
Cooking.
That's what the question is asking.
Please,
If you want to learn cooking. If you want to learn cooking, try to be a neat cook. Said Jacob's mother. So, Mr.
Mr.
Adam,
Idris.
I don't gave his never.
Yes. Who wants to try?
Hypotension. I'm taking
Hypotension. Do we all
because
agree?
we say with a neurogenic shock, the heart rate is bradycardia. So the
Okay.
A is but hypotension because of vasodilation with decreased venous return, leading to the hypotension.
Okay.
We said with the fecal impaction and what urine retention. So that one is also out. There's no vasoconstriction. It's it will be that rather.
So you see, the question looks very simple, but look at the choices in there. I think questions like this, before you even start reading, you will have your own answers in mind. But when you come and look at the options, you will see that they have a different plan for you. And of course, so you ask yourself, which one among the options here goes with neurogenic shock? It's more of hypertension. So like our sister said. So you are right, okay? Let us go through well and Let's see. I think there are one or two things maybe you can pick up from here. Should we move on? I think we have another one here. A 22-year-old woman with paraplegia after a spinal cord injury tells the home care nurse she experiences a bowel incontinence 2 or 3 times each day. Which action by the nurse is most appropriate? Who wants to try? Hey, none of us. Wow.
I'll go for C.
Your explanation?
Okay, I'm going for C because fine, the woman said she experiences bowel incontinence 2 or 3 times each day. Even though she's suffering from spinal cord injury, that can lead to the dysfunction of your rectum. What's the name, the sphincters there, and that can also cause the incontinence. But you, the nurse, need to also do your own assessment first to confirm whatever the woman is saying. So first of all, you have to assess. That's the information for the movement, for frequency, consistency, and then the volume also. You also need to do that. Any other options with the one insert a rectal stimulant? I don't think it should be appropriate for somebody who is already having a bowel incontinence to take high fiber food. No. And then to also instruct the patient to avoid all caffeinated. And it's not really related to the bowel incontinence solving. No. So that's why I'm going for option C.
Wow. Very good. Very good. Who else has a different opinion?
Me too. I'll go for option C, although I don't understand the question or whatever, but I believe that I remember they said if you don't have more clue to what the person is experiencing, the first thing you do is assessment. So that is why I'm going for C.
Come again with that point you just said. When?
I read it somewhere that if you don't have a clue about what the patient is experiencing, you've not gathered a lot of information about what the patient is experiencing, the first thing you do is to assess for yourself. So I'm going for C because the patient is now complaining. So as a nurse, you have to assess and see the severity of the problem before you can solve it.
Of course. Okay. I think we are all making a point here. So that is the right answer. Okay. That's the right answer. Thank you for your contributions, all of you. All right. So that is it. Please, if you are here and you still don't understand why the answer is C, can you let us know? Okay. Someone with paraplegia after a spinal cord injury tells the home care nurse, that she experiences bowel incontinence 2 or 3 times each day. That is what you, the nurse, you've been told. Will you just rely on what you've been told? Of course, with respect to these options here, will you rely on only what you've been told and go ahead with your interventions without having, without being, or let's say having a feel of what the patient says, without having a feel of it, or without seeing it or verifying it yourself? Will you just get up and implement or go ahead with a goal? You have to assess first, then you will know what to do. Okay. So I agree with you. That's I see. Okay, let's carry on. This one, we will have to do it together. Let others apply. The next is helping a client with spinal cord injury to establish a bladder retraining program. Which strategies may stimulate the client to void? Select all that apply. So let's start with the first one. When I mention your name, you tell us whether it should be part or not. So we want strategies that can help patients to what? To void or to urinate. Okay. So the first one, stroking the client's inner thigh. Stroking the client's inner thigh. Is that Abigail? Is it true? Hello? Is that Abigail Chairman? Is it true? Okay, it's Ruth. Is it true? Anyone?
Yeah, I'll go for stroking.
Do we all agree?
Yes, sir. Yes, please. Sometimes it works.
Yeah.
Yes,
Sometimes
please.
it's like saying. Okay. So this is not my handwriting. It's your very own handwriting. Is that Gloria? Are you asking a question or you're answering?
I wanted to say A is part.
You wanted to say it's part, eh?
A, yeah. Option A
Okay.
is part.
So your handwriting. What about B? All of us.
Yes,
Is it
please. B. Yes, it's part.
pulling on the client's pubic hair?
No,
I'll
Someone
I
has
choose
don't
that
yes.
think
one.
it's fact.
No, it's
I'll
not
add
part.
it.
These people
I'll
tell
add
you
it.
that you've been them.
Okay. Is it part? Yes or no?
No.
Yes.
It's not part.
Okay. So
All
some are
right.
saying yes, some are saying no. Let me put a asterisk near it. The next one, initiating intermittent straight catheterization.
No.
no,
No, please.
I'm interested in C-section. What do you say?
No.
No.
No, I said I'm interested in the explanation. What do you say with the C?
Can I say something?
Yes, you can.
Okay. In the question, it says you're trying to establish a bladder retraining program. I mean, you're trying to train the person not to even use the catheter. So why would you setting a catheter in the first place? Like, I mean, guess the reason why you're training the person in the first.
Good. That's the point I was trying to, or I wanted to hear. That's the point I wanted to hear. Well done. Well done. All right. So this is not part. What about option D? Pouring warm
Yes.
water over the client's perineum. Is it true?
I'll add it. Yes, please. Yeah.
Some are also saying no for this.
I'll choose yes.
Okay. Yes
I'll
or
go
no?
for yes.
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 The yes is plenty. E. Tapping the bladder to stimulate the detrusor muscle. You know, that's the
Yeah.
main muscle of
Yes.
your bladder, urinary bladder. So that is true, right?
Yes.
Yes.
The last one here. Reminding the client to void in the urinal every hour while awake.
Now go for
True or
A.
false?
Confusing.
No, it will distract the patient's sleep.
Every eye too close.
Okay. Okay, so wait. You are saying every hour is wrong, right? Are you saying it's correct or wrong?
Yeah. So we are saying it's wrong because mostly it
While
should be
awake,
every
okay.
2 hourly.
What about 2 hours? Is it true?
Yes, 2 hours is
2
true.
hours will be okay.
Oh, okay. So you already know your content. Well done. So the answers are between A, D, and E, right?
And probably B.
And probably B,
B,
yes.
B stoppers.
Yes. B for boy. You say you sit there and say it's not fat, okay? It's someone's major choice. Okay.
I'll support them.
All right. So let
Put him on the
us
client
carry on
pubic
with
hair.
this.
Hey,
Okay.
fat.
B is fat.
Yeah.
So check it again. B is fat, okay? So whenever we see it elsewhere, can we continue?
How does that work?
Me, I was about to ask. Hey, pubic hair,
You were about to ask and you didn't ask.
And
How
this
does it,
people,
this
I'm
one
actually,
there.
how does it stimulate
That's
the
why the
bladder?
emphasis in ever fun is that cause
Pulling on the client's hair.
Sensation is
Yeah,
fat.
the pubic
Please,
hair.
who can help explain that to me? Someone should try at least. And so that I can
I
find
think
the
the
nearest.
sensation you get when you go.
Please, one after the other. Who is talking? Someone should try for us. Who wants to talk? Oh, we had a lot of people talking. Now no one wants to talk.
no,
Is that Janet? You want
Hello.
to talk? What's that, Gloria?
no,
It's Gloria.
Okay.
I chose. I wasn't for it, so I don't know how I will explain it.
No, those who chose it to be part of the answer.
Okay, so I'm saying that the sensation you get from the pulling, yes, can cause you to void. Yeah, that's what I know.
Please, I didn't hear you all. I don't know whether it's my line which is breaking.
I'm
you come
saying
again?
that the sensation you get from the pulling of the hair can make you void. Yes.
The
That is
sensation
my
there.
yes.
Okay. So we have so in literal sense, yes. So let me see. Is this person talking to us? Okay. So generally, what it means is, I mean, that is what I've started. Sensation. Okay. We have something we call cutaneous vesical reflex. So I mean, it's a type of sensation. Okay. You have a sensory stimulus. I think it's even has a connection to do with your pudendal nerves. You know your pudendal nerves, right? It has, I think, pudendal nerves involved.
yes,
Yes, I think it's a nerve around your
Perineum.
perineum, yeah, around your perineum area, yeah. Okay, so there's some kind of reflexes around there. I can't explain it clearly, but yes, there's a sensation. That sense signal to all those parts, okay, which causes sensory stimulation. Then in one way or the other, it will cause bladder contraction and help to relax the tristle muscles with the sphincters, okay, the sphincters, then eventually help in the micturition process. So that is it. So let us keep it. As someone said, for English sake, okay. And I mean, it's factual too. It's factual.
please, I have
Let's
a
take
question.
another one. Okay.
So if let's say a male nurse is doing that to a female nurse,
A male nurse.
a male nurse is doing that to a female patient. Sorry.
Please, okay,
These people.
let me create an idea. Okay, let me I understand what you are saying, but every hair is a hair. Eh? Every pubic hair is pubic hair. But wait, let me make something clear to all of us. not all patients are unconscious. Okay. Not all patients are unconscious. Most of the patients we talk about, they are very conscious. If a patient is unconscious, definitely, or semi-conscious, definitely the person might be having an indwelling urethral catheter just for urine monitoring, like intake and output. All right, but these people, most of the times, we don't even encourage, unless maybe unless Sister Cynthia. So unless maybe you want to actually measure someone's urine output, okay, because of maybe a condition like, let's say, DK in acute cases or sickle cell conditions that maybe you need to adequately monitor intake and output. But if, not necessary in that sense, you don't have to, especially if the patient is conscious. Catheterization is not necessary, okay? And with this person who, look at how this question is, bladder training, retraining program, it means this person is actually conscious. Because someone who is unconscious will never undergo bladder retraining program. You get it? So in this case, even if you can't do for the person. If the person can do it by him or herself, the person can try. So that is what I want to say. Okay. But so sorry, I think my network was off. Can you hear me now?
Yes, please.
Okay. So what I was trying to say about that is, we have female nurses who clean up male patients, and we have male nurses who also clean up female patients. Okay, so when the need be in this case. So that is nothing. Any other question? Can we move on? Let's pick this question too. When caring for a patient who was admitted 24 hours previously with C5 spinal cord injury, which nursing action has the highest priority in this case? Caring for a patient who was admitted 24 hours previously with C5 spinal cord injury. And we're asking which nursing action has the highest priority? Who wants to try? You can unmute or you can raise up your hand and let's talk.
Okay, I'll go for option B.
Continuous cardiac monitoring for bradycardia. Okay. Option B. All right, let me take maybe one or two more before I come for explanation, okay? Otherwise, you write someone off. Please, it doesn't mean what she said is correct or wrong. I just want to take in more views. Who wants to try?
Please, option B. Thank you.
Okay. So we have two people saying option B. So it's like we fall together, we rise together, right?
I'll go for option C.
Option C.
I'll go for A.
Okay, so let's start with A. Let me hear your points. Why did you say? Your reason for your answer is equally important as your answer. Okay. What did someone choose say? Or the person is backing off. Okay, let's go to the B people. Who chose B? Like, why did you choose B?
Spinal cord injury.
Mm-hmm.
Then 24 hours.
Mm-hmm.
Okay, so if it to be the first few hours or first 24 hours, I would have gone for the respiratory because it's spinal cord and it can affect the respiratory muscles. That's the trachea and those. So it looks like at this moment, patient is a bit stable. So he now has the risk. Hey.
Oh, continue. I'm interested.
You've already shown the answer.
Oh, I was enjoying your explanation.
It's okay.
Oh, okay. Okay. But the explanation was nice anyway.
I was thinking that if the first few hours, I would have gone for the respiratory rate.
Okay.
But at this moment, it looks like patient is a bit stable. So the next thing we might be looking at for is the neurogenic shock, which to me, B shows, gives me like some of the features you need to look out for, monitoring the cardiac monitor for bradycardia, which is a sign of a neurogenic shock. That's how come I was going for the option. Yeah.
Okay. So thank you for your explanation though. But let us take note about one thing. When you have a spinal cord injury, okay, and let's say today you are able to breathe, tomorrow you're able to breathe normally, it doesn't mean that after 24 hours or after the first few hours, you can't have a respiratory complication. So take note, it doesn't always occur immediately. Okay, so what should be your guide here? Any of them can come or they can happen every time, like any time within the condition. It shouldn't be like, there's no one way pattern to it that this one should come first before this. When you have a spinal injury, so we have classification or a group of signs and symptoms. You can get any of them, anyone happening at any time. Okay. You can just some can even precipitate some funny neurologic conditions that will start numbing your limbs. Then later you get respiratory condition or respiratory part also affected. So let's look at what the question wants us to do. You are caring for a patient who was admitted 24 hours previously with spinal cord injury, C5. So which nursing action is the priority? So you have a C5, and C5 innervates your thoracic, like your rib cage. I think it has something to do with your respiratory centers too. With the innervation pathways, I might not be able to say them right now. The innervation pathways, but it has something to do with respiration. Okay, so please, even if it was a thoracic vertebral injury and respiratory was there, in this question, you should use your EBC. In questions like this, use your EBC. Okay, so all of them, you see, this one will occur in this patient, the option B. Option A2 will occur in this patient. All right. But which one do you think is the priority? C and D shouldn't be part because they do not reflect assessments. In most cases, when especially you are unsure, or if your time is up, you are nearing your exam, let assessment, like those minor tricks, let them ring louder in your minds, okay? It's very, very important. Let them ring louder in your minds.
And please, can I ask a question, Mr. Ima?
You can ask.
Yes, and please, if in case the C5 is changed to T3 or T2, what would the answer be? Is it going to be the same assessment of respiratory rate or the
If
B?
she was seen to,
Yeah. If C5 was rather changed to T2 or T3.
yes, it will still be respiration.
Oh, okay. Oh, okay. Thank you.
Okay. You see, but wait, when you have a thoracic vertebrae injury, you ask yourself, can it affect your respiratory center? Let us find out first.
Yes, because the thoracic area has the lower part of the respiratory system.
Okay, good. So it means that that is also possible. So in this question, you use your ABC, okay? Use your ABC. So I think thoracic and cervical, they can both affect your, unless something which is not related at all. If it's not related, then fine. But if it is related, please use your ABC. They are all in the same group.
Please, what's the ABC?
ABC, airway, breathing, circulation.
Oh,
Okay.
okay. Okay.
So in this case, your first one is like more of B, right? Breathing. Then option B becomes C, like cardiac monitoring is for circulation. All right.
Okay, thank you.
You're welcome. So this is the rationale in brief. All right. Let's look at another thing. So I'm sure when you get some questions on autonomic dysreflexia and neurogenic shock, at least you'll be able to do something, right? Okay, let's look at another area. Intubated patient who has a drop in oxygen saturation level. Okay. Let's say you have patient who has been tubed and connected to a mechanical ventilator. And at a point in time, this patient's saturation levels are dropping. Let's see what we have here. You're saying a drop in oxygen saturation signifies ventilation problem. When an artificial airway is present, assess patients to determine cause of hypoventilation. You remember, I told you whenever a patient is on a mechanical ventilator and it starts making noise of an abnormality, okay, the sound alarm system, the sound or alarm system starts beeping. When you go to the patient and you want to check out what is happening, assess patient first. Okay, if patient is in immediate danger, you disconnect patient from the ventilator. Then you can ambibag. Okay, you bag the patient with an ambibag or BVM, bag valve mask, whilst the issue gets resolved, or you let another person check on the issue. All right. So we are saying when this happens, auscultating lungs sounds first. You have to find out whether there is air entry into the lungs first. Okay. And quickest intervention to confirm proper tube placement. So sometimes the tube too can come out no matter how strong you strap it. Though we have I mean, it's very different in most cases. I mean, how the strappings are done in most settings. Okay, but when it's done well, even if it's done well, it can still dislodge or something can happen to cause hypoventilation. Okay, so when that happens, what you are saying is that we have to make sure you've taken control of the patient's airway. Let me show you something here. I think last time we met, I displayed similar thing here. Let me use this also ventilator. So like this, a patient is on a mechanical ventilator. You've taken care, let's use this one, okay. You've taken care of the airway. I mean, you've taken control or something like that of the airway. So this is the only way through which the patient's taking oxygen. So when you find out that maybe on the monitor connected to the patient, the saturation levels are coming down, you go to patient, you use your stethoscope, you auscultate the lungs, okay, to see whether there is actual air entry. Sometimes it could be maybe an air leak, okay, or secretions in the tube. Sometimes when there are secretions in the tube, you could see, or patient can cough, and you hear that mucus sound, like, you know, when a mucus is found or a fluid is found in the tube. Sometimes you hear that rumbling sounds and all of that. That should tell you that patient has secretions. Patients can sometimes cough, but you go and auscultate. If there is adequate air entry, fine. But if there are secretions, you can even hear it from auscultations. Okay, you hear this transmitted, I think, bronchial sounds. Like you hear it from the upper parts. You hear those rumbling mucus. I mean, you find it. The sound you hear is very spectacular. It's very different. So if it's because of secretions, then you can disconnect patient and suction, but you still have to follow the right way. You suction with sterile glove, you hyperoxygenate patients. Ventilators have that hyperoxygenation settings. So every ventilator will have it, okay? So you will hyperoxygenate for about 1 to 2 minutes, then you can enter to pull out saturation and secretions from the patient. But if it's an emergency, and even in questions like in emergency questions, after assessing, you know, I mean, like this slide we're talking about, it's more of assessment. But I'm speaking in general terms. If you find out that patient has secretions, you can turn on your hyperoxygenation button whilst you quickly put on your sterile gloves. Then you disconnect patient immediately in suction. And suction should not last for more than 10 seconds per suction, okay, or per entry into the tube. So this is what we want to say, okay. So whenever you see that, you know, this is a ventilator, patient will also be connected to a monitor. Whenever you see that the saturations are dropping, you go, I'm repeating myself for the last time, patient. So in some questions, you not see auscultate lungs. You like the NCLEX has its own language, okay? But if you know your facts, nothing can trick you. That is the key word here. If among the options given, you are being provided with an assessment thing that is very related and can help the patient, you yourself, you know. And you know if you understand the whole situation. Okay. So we are saying also take the lungs and the rest. You might get similar question which will ask you to maybe disconnect patient a bag. Okay. That one too could also be right. Okay. Because patient saturation is dropping, disconnect patient. I don't know, maybe we have some questions ahead of us, then we can compare. So mostly depends on questions that you are. All right, back to our slide here. So we are saying auscultating lung sounds is the first step and quickest intervention to confirm proper tube placement. It is common for tube to become displaced in the hypopharynx. Okay, sometimes tube can even come out and the tip of it, instead of it within the trachea, it will be just lying around the oropharynx, the back of the throat in there. Okay. And that can also make patients hypoventilate or saturations can come down. So we are seeing another complication is what pneumothorax, which can cause hypotension and drop in oxygen saturation. So lung auscultation would help diagnose this too. So in a nutshell, any complication that is happening when you auscultate, you will find out. That's what you're trying to say. And like the fourth point here too, if there are mucus plaques, okay, that are within the tube and is causing this decreased oxygen saturation, then you can suction. You will hear from auscultation. Okay. Then we are saying there are, however, specific symptoms associated with this problem, including secretions backing up in the tube and high pressure ventilator alarms. So, especially when it's secretion suspect, because the secretions will mount up pressure within the tube connected to the ventilator, there are sensors in the ventilator which will sense, okay, and will start giving you a beeping alarm with some lights, okay, showing that there is high pressure. So you will have to know either the patient has bitten on the tube. So you go there, in this case, you assess whether the patient has intentionally bitten on the tube or secretions are a lot, okay, in the tube, so that you can resolve as soon as possible. If it may cause you suction, if it is patient biting the tube, you can talk to patient, orientate the patient well. If patient has passed that stage, then you can use something else, okay? Appropriate something per protocol to help release the patient teeth from the tube. We are saying although patients may still need suctioning even if these symptoms are not present. Okay, so auscultating lung sounds is also necessary to confirm tube placement before even suctioning to avoid damage to the airway. So that is all for that aspect and that scenario. Any other question? Any contribution?
Hello, sir.
Yeah.
Please, concerning the suction, can you please help me with the number of minutes you need to go in, that kind of thing? Some of the questions asked, and I sometimes, when the duration of suctioning, how many is it? 10 seconds? That thing. Please, I need help. Thank you.
This is 10 seconds, not more than 10 seconds.
Thank you.
Not more than 10 seconds. You found it somewhere that Not more than 20 seconds before, right? Hello?
No, I think mostly they say 10 to 15 seconds, not more
Um,
than 10 to 15 seconds.
but the ideal one, let's stick to the up to 10 seconds, okay?
Okay, sir.
All right. Any other question or addition? If not, then we move on to what we have here on our slide, the next thing to talk about. Guillain-Barre syndrome. Guillain-Barre syndrome. So Guillain-Barre syndrome is an acute immune mediated polyneuropathy. Acute, sudden, then autoimmune disease. It has something to do with the immune system, which causes many neural injuries or neural disease states, okay? And it's accompanied by ascending paralysis and absence of reflexes. So the trick to this one too is that sometimes you will not just see ascending paralysis or something. You can get a nice case study question on this one, okay? They can start with a nice presentation and they will tell you that maybe a week ago or 2 weeks ago, patients started having weaknesses in their limbs. Okay, then 2 days later, patients couldn't pass through for some time. Okay, so they will give you clues indicating paralysis, which is ascending. So it starts from your peripheries. So down, then it will climb up until it gets to your respiratory center, your chest. Then finally, you lose all control. Okay. You lose all control. You have weaknesses all over. You can't feel anything. So that is one thing about Guillain-Barre syndrome. Ascending paralysis. We have lots of conditions that will end up in paralyzing you. Okay, that will end up paralyzing you, but they are in different. Even myasthenia gravis has its own, but you know where it starts from. Something like from the face and it can come down a bit. So sometimes some people even refer to it as descending paralysis because it mostly starts from your face and you have this facial palsy and the rest. Well, some call it palsy anyway. But with Guillain-Barre, you start from your peripheries, then it climbs up. So you are saying lower extremities weakness progresses over hours to days to involve your thorax. As soon as, so you see, as it comes, when it reaches your waist area, let's say it started from your feet. When it gets your waist area, it numbs everything over there. Everything, I mean, every organ over there becomes paralyzed. So your front will be paralyzed, your back will be paralyzed. You know what comes out from the front, what comes out from the back? Urine and stool incontinence. So that is what will happen. Then as it climbs up, you know, it everything's happening internal and both external. Okay, it is just turning off all those signals. So when it reaches your abdomen, all your nerves will be paralyzed. That's why they tend to have lots of constipation because peristaltic movement will be lost. Everything that has something to do with nerves will be lost. So it will come up a bit, I mean, gradually until it reaches your chest. And this patient will be ventilator dependent. As soon as you disconnect patient, it gets to a level, and as soon as you disconnect patient from the ventilator, it will mean certain death. So that is Guillain-Barr syndrome for you. So you're saying neuromuscular respiratory failure is most life-threatening complication because, like I said, ABC, your airway and your breathing is very, very important to sustain you. You remember last week I said, I'm sure it was in this class or maybe last week I said that in general prioritization questions, you use your ABC, right? But when you are dealing with cardiopulmonary resuscitation, that is the only situation where you should use your CAB, circulation, airway, then breathing. Okay. All right. So you have to monitor the rate and depth of respiration. It's very important. Measurement of serial bedside forced vital capacity, like as in spirometer or spirometry, is gold standard for assessing early ventilation failure. Okay. So autonomic dysfunction is common and results in orthostatic hypotension, paralysis. So like I was saying, you get autonomic dysfunction, which is very common. Okay. You have orthostatic hypotension, change in positions that result in lowering your blood pressure. Paralytic ileus, all your intestines, especially the small one, they'll be paralyzed. Urinary retention because your bladder, all the nerves over there will be paralyzed. And diaphoresis, you'll be having sweating, extreme sweating. So that is what will happen in Guillain-Barr syndrome. Let me see whether there are more to add here. If not, then I'll see whether I can add. Okay, so let's continue from here. So absence of knee reflexes, they ask you, maybe which of the following is the most concerned information to follow up, okay, or to report to your healthcare provider or something. If you have something like absence of knee reflexes, it is okay because that is, but it depends on the question anyway. That is when you are prioritizing, okay. Let's say they've given you respiration, they've given you absence, knee reflexes, and the rest. You know, you don't have to choose knee reflexes over the respiratory part. And there are some questions that the knee reflexes can also be correct, depending on how the question is being asked. So they can tell you that patient came with maybe only feet numbness, and 2 days later, patient has maybe knee reflexes gone, and you know, though lots of things can make knee reflexes gone, especially with the electrolytes and the rest. But it always depends. Okay, with NCLEX question, it always depends. So you get the concept. When you get the question, then you can make application. Then you write. So you are saying absence of gag reflex indicates progression. So that means it has progressed to your head. Okay. Then you also assess for this pillar, whether pupils are equal, round, reactive to light, and they accommodate well. Accommodation. You assess for this cranial nerves. Please, for our own good, learn about cranial nerves, okay? For our own good, learn about cranial nerves. All right. So we are saying you should assess for cranial nerve 2, cranial nerve 3, 4, and 6. Nerves. Are we asleep or we are here? Then let's hear you out.
We are here. We are here.
I'm here, boss.
Oh, cranial nerve too. First one is olfactory,
Optic
right?
nerve. Optic.
If olfactory comes, then optic comes. Okay. Optic nerve, then the three becomes what? Another O.
Oculomotor.
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 Kumamoto.
Then 4, cranial nerve 4.
Trochlea.
Trochlea.
So trochlear nerve. So you see,
Yes.
optic, oculomotor,
Oculomotor,
then
trochlea.
trochlea. This one
Yes.
assesses both sensory and what? And motor function of the eye. So the cranial nerve 2 is more of sensory. I hope you know that. The optic nerve, it's only sensory. And trochlea is what?
Motor.
It's motor.
Motor.
So please, when
Yeah.
you learn the cranial nerves, try hard and
Their
learn
function.
whether they are motor or sensory or they are both. Some have both. Okay. All right. Please, if you have any question, you can ask. So let me ask, what actually causes Guillain-Barre syndrome?
It precedes a viral infection.
Okay, so the main cause is unknown. Okay, but we have factors that can precipitate it, like infections. Okay, so that is how we should put it. It's actually unknown. It's autoimmune. Okay, all autoimmune diseases are normally precipitated by some external factors. All right, so who is affected by Guillain-Barre syndrome? Let me help you. In terms of the sexes, is it more prominent among males or females? We are not sure. Okay, so it has equal predisposition among the two. Okay, so it affects all sexes equally. It doesn't discriminate in this case. What about age factor? Can you think about any? Do you have specific ages that it normally starts? This one to no one. So it can affect anyone at any age. Okay, at any age group, you can get it. All right. So per the little that we've gone through on Guillain-Barre syndrome, what are some of the signs and symptoms? Oh, at least we spoke about the weakness, muscle weakness, didn't we? Okay, so all that we spoke about, or is it that we are tired? Are we tired for the day?
No.
There's constipation,
There's constipation.
It's what?
paralytic ileus or constipation.
Is that someone's giving like you are
Paralytic
doing
ileus.
constipation? Okay, you're saying constipation, right? Like as a
Yes.
sign. Is that it?
Yes.
Okay, yeah. So that is when it affects your your abdominopelvic area, okay, when it climbs up and get that area affected. You can have tingling sensation, okay. around your appendages.
Can have
Someone will
urine retention.
come again.
Urine retention.
Yes, you have urine retention too. Good.
Diaphoresis.
Yes, yes.
Respiratory
Please, can you add numbness to it?
Yeah, tingling, numbness. Yeah, the upper part.
Please,
All
can you
right.
say like loss of like sensation? I mean, loss
Oh
of
yes,
feeling to touch or something. I don't
the
know.
upper part. Okay,
Oh, all right.
the upper part. So you lose sensation to. So it's like it affects both your motor and sensory function. So when you see this, think of all motor, think of all sensory. They will all be gone. Okay, you even when someone touches your hand, you will not feel it. That is when it affects your hand. You will not feel it, and you can actually bend the hand. Please, I mean it's impractical to even bend a patient's hand. I'm just trying to explain something. But should you even bend the hand if it has been affected? This patient will never feel anything. So you see how serious the nerves can be.
Please,
You
is
can.
it the same as the ALS?
So ALS has its own thing too. Okay. But at least the paralysis line is different. But sometimes how it affects how the nerves are affected, they are I mean they are similar. Okay, they are similar. Maybe when you mention ALS, some people are asking what is ALS for ALS, right? It's amyotrophic lateral sclerosis. You know, this one has no cure, and your life expectancy, I think it's less than 6 months or so. I mean, these are some, but this one doesn't follow the pattern like the ascending paralysis of it. Okay. So amyotrophic lateral sclerosis, like you said, is also part, but it has its own way. And you have degeneration of these nerve cells. Another name for it is Lou Gehrig's. Lou Gehrig's disease. We'll do that. I think we have that ahead of us somewhere. Any other question? I was asking the question about Guillain-Barr, right? Or someone asked the question. I was saying that because there is both sensory and motor function loss, all because of what? Distraction of myelin sheaths, or generally distraction of nerve cells. These patients won't feel anything, whether heat or pain, any sensation. These patients will never feel. All right. But how do we diagnose it? How do we diagnose it?
You can do a lumbar cancer, and with this, proteins will be high.
Good. Proteins can be high, but it's not, we don't have any isolated protein to specify, okay? But just that proteins in your CSF will be high because of the distraction of the myelin sheath. So that is the idea. And that even occurs more with other neurologic diseases. But what will be more prominent is your signs and symptoms, okay? How your paralysis occur. So that is more golden to know that this is Guillain-Barr. But how do we treat it? Does it have a cure? Can we cure it?
This
No.
lateral-sclerosis, it's
No,
not a
it's
cure,
not
but there's a treatment.
Good. So all autoimmune diseases, not only Guillain-Barr, all autoimmune diseases have no cure. Almost all. Okay, almost all. They have no cure. But we have drugs that can help and their drugs are similar. Okay, most of them are similar. Not all, but I mean about 90%. Their treatment modalities are similar. You will have to do plasmapheresis. Plasmapheresis. I don't know, apart from, sorry to say this, in Ghana here, I think apart from Accra Regional Hospital, I don't know where else we have some of this machine. We might have them elsewhere, right? But so you can do plasmapheresis. I know we have rage nurses here. Can do plasmapheresis, then immunoglobulin. Okay, immunoglobulin therapy too can be done. These things they are very expensive. If you've treated or you've cared for a person around I mean about such conditions before, you'll understand. Plasmapheresis, I think we had some done over here at our ward, and the price alone in Ghana cedis, I think it was around 60,000 plus. Okay, the plasmapheresis alone. Then immunoglobulin to around somewhere early this year or later I think later last year, one for 5,000 Ghana cedis, and you will need about lots of doses. So it's very expensive. It's very expensive. So, well, all right. I think we can continue if there are no other questions or things to add.
Hi, sir. Please, I have a question.
You can ask.
My first time here, and I like to know how long our discussion on or our studies do take.
It's Beatrice.
Yes.
Okay. So, who is your supervisor?
I think, is it Yakut?
Okay.
Yeah.
All right. That cool boy. All right. You after the class, just
Okay.
message me. Okay. Or you can
Okay.
message me. Okay. We'll sort
Okay.
you. Yeah, I
Okay.
think you
Okay.
have to be good. Yeah. And
All right.
please, if you have similar questions, you can ask your supervisor. Okay. All right.
Okay. Thank you.
You're welcome. If there are no further questions, then let me ask you a question. The first one
Please.
here. You have a question, eh?
Yes, I wanted you to explain the force vital capacity for me, a very brief of it for me.
Forced vital capacity. When you blow air, I think under pressure. When you blow air under pressure, I think it's being measured. When you blow air, should I say exhale, right? I don't know whether there's I think there's a way that they measure it. I don't know how it's being measured, but what I know is that
I think it's measured through capnography.
capnography. Okay,
Yeah.
good. But forced vital capacity is just like it's the name for air. Okay, it's like we have vital capacity, we have forced vital capacity, we have tidal volume. Is it tidal air or something? So they are just names for air that you take in, but under different situations. So forced vital capacity is the maximum is like one that you breathe out forcefully from your lungs. Okay. So thank you. So as I said, you use the to measure that. Please, are you okay?
Yes, I'm fine.
So you can look at the other parts too. Okay, not look at, because who knows, maybe you might meet it somewhere. Apart from the force vital capacity, you have the vital capacity to the end, the other parts. There are terms in respiration, inhalation, exhalation, mechanisms, those series. All right. Any other question? Okay, if not, this is my question. Which assessment data?
No, guys, no.
Please, was someone talking? All right. Which assessment data? But can you all hear me?
Yes, we can hear you.
All right. Which assessment data should the nurse assess in a client diagnosed with Guillain-Barre syndrome? Who wants to try?
Hello.
Yes.
Okay, please. The answer is 4 because you just said it's ascending paralysis. So it's progressive ascending paralysis of the lower extremities and numbness. But for the number 1, you didn't say anything about that.
So, so let me ask everyone generally. Is this question difficult?
No.
No, it's fresh in our minds.
I'm asking again. Is this question difficult?
No, it is
So
fresh
this is how
in
the
our
English
minds.
is. Okay, that's how the English is. You won't say amen.
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 So what it means is that if you know your facts and you've learned well, okay, it will appear. I mean, as you just choose the answer. So let us try and put in much effort in our studies, and everything will be like we are drinking porridge. Let's pick the next one. Please, just in case you have a follow-up question, don't hesitate to ask, okay? We'll help you. Which statement by the client supports the diagnosis of Guillain-Barre syndrome? You see, this one is more practical.
It's B, number 2.
What? Who wants to try? Wait now.
Okay.
It's 2.
It's option 2.
You pick option 2.
Yeah.
Any rationale?
Right. So we said Guillain-Barre is an autoimmune condition. It can be precipitated by some factors following factors like post-viral infections, especially those respiratory infections. So the person said he had a really bad cold few weeks ago. So that can predispose you to getting Guillain-Barre syndrome.
Good. So that even though Guillain-Barre syndrome is an autoimmune disease, but you should have something precipitating it before it comes. Okay. And the most common thing that can normally precipitate this is infection. Okay. Infection. Both viral and I think it's more of even viral. I read it somewhere. Okay. It can easily precipitate this I mean most of this immune mediated diseases, autoimmune diseases in this case. So these are rational. So this syndrome is usually preceded by respiratory or gastrointestinal infection. So 1 to 4 weeks prior to the onset of the neurologic symptoms. All right. Let us move on. So we end that part 2. I think we've said enough about Guillain-Barre syndrome. Sister Priscilla, you can ask your question. Then we talk
Yeah.
about something else. I can hear you. Can you hear me? The line is breaking. Is it from my end? Please, the rest of you can hear
Hello?
me. I think it's better. Hello.
Hello?
The rest of you can hear.
Please. Yes, I can hear.
Yeah, we can hear you. I
Esther
think
Priscilla, your network. Esther Priscilla,
Yes,
if you can hear
please,
me, can you check it?
yes, I can hear you. Can I ask my question?
Oh, yes.
Okay, I just wanted to know the answer for the previous question, the one that had the, is it ascending, the Guillain-Barr, the first question we answered. I lost my network for some time, so I couldn't hear anything.
This one. Was it this one?
Yes, please, this one.
Oh,
Was it
but
4?
okay, I wanted it to do.
I just
Yeah,
want.
but it was 4.
Okay, all right. Thank you. Thank you. Sorry for the network.
You're welcome. Okay. So let's talk about another thing here. So you have hypothermia. When you have a patient, you have hypothermia, like an emergency form of this hypothermia, somewhere at a temperature of below 35. You will have to raise the temperature to an optimum level. So let's see how we do it. What is important to note? What should be done and what should not be done? It's very important. So let us grab the idea here. If you have the knowledge about the normal or the right thing to do, whenever you see a red flag anywhere or a wrong thing anywhere, you'll be able to see clearly that this is wrong. It's never done. So let's move on to see what we have here. Hypothermia occurs when the core temperature is below, Hypothermia occurs when the core temperature is below 95 degrees Fahrenheit, which is 35 degrees Celsius. On the end, we give him both, okay? And the body is unable to compensate for heat loss. As the core temperature decreases, the cold myocardium, when you are cold, your myocardium too is cold because it is blood which distributes all your heat to all parts of the body. Most of the heat production occurs at where? In the body. Anatomy and physiology, that's where. Most of heat production in your body occurs where?
Skin. In the skin.
Are you sure? Is it not liver? Is it not
Is there a
liver?
question?
Come again. Okay. So your body, your blood will distribute or will disperse this heat, okay, all over to the rest of the body. So when you are cold, it means your myocardium too is cold. And it becomes extremely irritable and prone to what? Dysrhythmias because of the extreme cold. So hypothermia can lead to you or can lead to a patient getting dysrhythmias. So that is one thing to note here. Hypothermia alone can lead to dysrhythmias. And how it happens is it irritates. Okay, the cold myocardium becomes irritated. Okay, and the ECG reads how your myocardium is functioning. It reads how your myocardium is functioning, and if it's irritated, it can cause it to shiver or quiver or give you any form of dysrhythmia. So the client should be handled gently in this case, as spontaneous ventricular fibrillation could develop when patient is moved or even touched. Therefore, placing the client on a cardiac monitor is your highest priority. So when patient has extreme hypothermia, your first thing to do is to connect patient to the cardiac monitor. Please, it's not to provide warmth. That's not your first thing to do. Your first thing to do is connect patients to your cardiac monitor, because remember, raising the temperature up will take time. But in the meantime, when patient is being connected to the cardiac monitor, if there is any impending dysrhythmias, it can be seen earlier and treated quickly. Okay. So the nurse should anticipate defibrillating in these clients. That is, if only you have a shockable rhythm. I mean, patients are already been exposed and patients run into ventricular fibrillation or any form of shockable rhythm, and it's indicated to shock, then you can do your shocking. I think most of us, we've had EKG class, and most of us will just watch it. At an appropriate time, we will do it in live class so that you have a live coverage and maybe check on other things around electrocardiogram. So covering the client's head is indicated to prevent heat loss. However, can be done after the cardiac. So you see, it's like when you have options that you have to compare. Also options like one, a patient who has a temperature of 35 or anywhere below, which of the following actions is the most priority? So you have option one, like connect patient to a cardiac monitor. Option two, cover patient head. Cover patient head. Okay. Option three, warm patient or give patient something. So, I mean, among all of them, connecting patient to cardiac monitor is your most priority intervention. Then we are saying, so covering of the head can be done later after the monitoring. The next one, you're saying, depending on the severity of the hypothermia, the trunk should be warmed before the extremities to reduce risk of what? After drop. Okay, to reduce the risk of after drop. Okay, I wanted to add temperature. So what this one is trying to say is that when you have patient who is extremely hypothermic, if you want to correct this hypothermia after connecting patient to cardiac monitor, you start warming these patients from the trunk, okay, before you get to the extremities. Otherwise, you will end up crashing the patient's temperature. Okay, that means temperature of patients will go more down. I mean, more, it will go down the more, okay? To go down the more, and that will not help the patients. Do you know, I think we have it even ahead of us. We have some conditions where we intentionally induce hypothermia to treat neurologic conditions, okay, or to help with neurologic improvement. When we get there, we will look at that one too. So you are saying this is due to cold peripheral blood returning to the central circulation. So 2 large bore IV catheters are preferred. Then this can be accomplished after the cardiac monitor has been attached. If you have any question, you can ask. So when you have severe hypothermia, this is how you do. Okay. You warm the trunk first before the extremities. Okay. And you've also learned from this slide that extreme hypothermia can cause lethal dysrhythmias, like even VFib. It doesn't mean that VFib is the only thing that you can have. Patients can even get PVCs. PACs too can be there, VTACs, so anything can happen. So that's what we are trying to say here. Then how you handle it, that one too, we've talked about it. Sister Priscilla.
Yes, hello, sir. Please, in the third paragraph, it says covering the client's head is indicated to prevent heat loss. So, and then it says in the fourth paragraph that the trunk should be worn before the extremity. So, does it mean like when you connect the cardiac monitor, you cover the head before the trunk, before the extremities? I just need to understand that.
So
Thank
the
you.
cardiac monitor, I think the leads are connected to the chest, right? The leads are, or maybe I didn't understand your question. The leads are connected to the chest, then you can cover patients. Cover the head doesn't mean you should cover the head alone. You cover the whole body, but with the head too.
Thank you. Okay, yes, sir.
You're welcome. So it doesn't mean cover only the head and leave the other part. No, it's impractical. Please, any other? Okay. If you don't have any question, maybe I have some for you. The nurse caring for, oh, sorry. The nurse caring for a client with hypothermia understands the compensatory mechanisms that are activated during this condition to decrease oxygen demands on the body. Which clinical manifestation should the nurse expect upon assessment for this client? Mhm.
I think there will be increased heart rate. Increased heart rate.
Increased heart rate. Increase or decrease? What is it?
Increase.
0.3.
Yes, please.
0.3, like increase, okay.
Yes, please. Because in the presentation, you made it known that with the hypothermia, it will let the client get arrhythmias.
It will let the client get what?
You said is it defibrillation or arrhythmia? I've forgotten the right term. So
Okay.
because of that, we should always attach the cardiac monitors before think of covering the client to produce heat or something. So I will go for the C.
Okay.
Okay.
Then what else? This one is select all that apply. So you're choosing. Okay, so select all that apply can even present itself as one being correct. You can have all of them to being correct, or you can have only a few. So choose all your answers.
So, Saima, the question is saying that compensatory mechanisms that are activated during this condition to decrease oxygen demands on the body. So that's what the question is asking for.
Come again with what you just said.
So the question is saying the nurse is caring for a client with hypothermia, understands that the compensatory mechanisms that are activated during this condition is to decrease oxygen demands on the body, right?
So there's a clue here. So there's a compensatory mechanism that happens when you enter into this hypothermic state, just to decrease your oxygen demand. So there's even a clue here. In other words, what will help to decrease your
Increase respiratory rate. Decrease respiratory and decrease heart rate.
We've given ourselves the clue already, right?
Yes.
So is it difficult? You see the trick here? So sometimes most of the questions that we solve, paying attention to the details in the question will help us. Okay. It will help us a lot. Okay. So we are correct. In this case, let me clean and check answer. Yes. Was it difficult?
Sayima, let me ask a further question to this.
Okay.
So, are you trying to say that during a hypothermic state, the body has a mechanism of decreasing oxygen rate? Why is it so? I just want to know the
Please, I
physiology
don't understand though.
behind that.
Okay. Okay.
Please, I don't understand.
We have something, okay. We have different mechanisms, but I know of only one. Let me share with you. Generally, when you have low temperatures, your vagal nerve, so I said your vagal nerve, your vagus nerve, which is cranial nerve, what? Is it 10 or 11? 10, right? Cranial nerve,
10.
what?
10.
Vagus.
Yes, it's 10.
Yes, vagus nerve, cranial
It's
nerve 10.
10.
All right. That is the nerve responsible for these vagal stimulations and the rest. You know, it innervates. I think when you look at the roots around your neck to your chest, that area, okay. Then I think yes, I know of around your neck and your chest. So it has a role to play even in respiratory rule, okay. So in extreme coldness, like 35 degrees and below, what happens is that the vagal nerve or the vagus nerve becomes stimulated. Okay, they become stimulated, and when the vagus nerve is stimulated, you have heart rates coming down. Do you know that those of you who have gone through the EKG lessons, you remember you learned something that even when someone has extreme high heart rate, whether
This is a sinus
tachycardia,
tachycardia.
yes,
Okay. Infarctic massage.
yes, you do your vagal stimulations, and if they don't work, you come to your chemical means, that's the use of the drugs, then before you go to your mechanical means. Okay, so it's more of, we have other mechanisms that also happens in conjunction, but in this case, I know of the vagus nerve, which plays this function. So the vagal nerve or the vagus nerve becomes stimulated. Then, when the vagus nerve is stimulated, it tends to decrease heart rate and respiratory rate too, in one way or the other. Do you know that bearing down and holding your breath as if, let's say, bearing down and blowing air out with your mouth closed, okay, your nose and your mouth closed tightly, it's a form of stimulating your vagus nerve.
Yeah.
You know that?
Yes.
Good.
Yeah.
When that
And
happens,
eyes on the
at that point
face.
in time, are you not even slowing respiratory and heart rate?
Yeah, you are.
You are slowing both. So that is what I can say about it. I know there are other mechanisms, but this is the easiest way we can grab it now.
Sir, please, I
Okay.
also read that gag reflex also does that. Like it can actually stimulate the vagus nerve.
Gag reflex does what?
It can stimulate the vagus nerve. Like I read.
Good. So you see, it's around the throat. The vagus nerve innervates your neck, like I said. So it's also part. Okay. It passes around your neck. You know, gag reflex is in your neck. Okay, the back of your throat, around there. And I think it passes around your sternocleidomastoid. Like, the anatomy is plenty. I've forgotten plenty. Okay.
Bosima.
Yeah.
And please, I learned that you dip your face into cold water or you wrap ice on a towel and put it on your face.
To help solve what?
Sinus like vagus nerve stimulation.
Yeah, vagus nerve stimulation. Good.
Okay.
Okay, that one
Please,
too
can you
is
come again? You say you take some code and wrap around what?
You take an ice and you wrap it in a towel and put it on your face, or you dip your face in cold water. Yeah.
Okay, thank you.
All right, thank you. So even this one, even if you never knew the rationale, okay, per the trick we all figured out here, it should at least be your guide to choosing the right answers. Okay. Compensatory mechanisms that are activated during this condition to decrease oxygen demand. So even if you don't know what really goes on in here deeply, what options or among which options here can help decrease oxygen demand, then that becomes your answer. Okay. That is when you have reached your last gram and you don't know which way to turn again. Another question here. So which client is at the greatest risk for hypothermia? Take your time. So take it as if you have this question on your case. What answer will you choose? This is your last question to determine whether you pass or fail. So choose your answer and pass. Let's see what you choose.
I'll go for option A.
And your reason?
You know, this aged, they have less fatty tissues, and during the cold weathers, they are very predisposed. They are predisposed to it. Most of them too are pensioners, and their incomes are low. They are not able to purchase the heating bills, so they tend not to switch on their heating system, and that can lead to hypothermia. Yeah.
Okay. Is we all agree?
Yeah.
Yes, sir, we agree.
Okay.
Yes.
Someone is there, the person don't agree on, but he or she is joining everybody.
Sir,
Shout out to you if you are part.
please, what of the worker who works in industrial freezers? Like, I'm just.
I wanted you to bring your point. A worker who what repairs industrial freezers.
Yeah, like,
So,
what
so some of
about.
the freezers will get into the person. That's just by the way.
So I think with that scenario, the person, it didn't state that the person is exposed to the freezers. The person
Yeah.
repairs the freezers, but they are not exposed. It didn't state like,
If
yeah.
you work
working gear.
If you work at ECG, like I mean electricity company of I mean wherever you are, your country, it doesn't mean you get shocked every day.
Yes.
Okay. So that is the meaning of it. But it's
Those
good.
guys typically wear their working gear.
And even they even turn on the electricities before working on this freezer. So I don't
Okay.
think, yeah.
Let's look maybe our last but one question on this one. Hypothermia. A client with severe hypothermia was found unresponsive. The cardiac monitor shows pulseless electrical activity, that's PEA, after 15 minutes of performing CPR. Which should the nurse's next action be? It's a tricky question, eh?
One. It's one.
Yes, I think it's A too.
Yeah.
Yeah, your
It's not the
reason.
watch it straight.
I'm gonna watch already.
One.
Why do you okay? Give
I'll
me a
go for
reason for one.
C.
I'll go for B. I'll
Please,
go for
for this one, I'm
B.
interested. When you say your answer, let me know why you choose your answer.
Hello,
I'll
sir.
go for
One after the other, please. Who wants to talk?
Okay. I think I'll go for A, which is not the time of death. I mean, it says that the cardiac monitor shows pulseless electrical activity after 15 minutes of performing the CPR.
Continue
I'll
CPR
say
for 20 minutes.
This is
oh,
English. Oh. Analyze the English very, very well. English and their English. Take it one by one and follow as if you are in the picture doing it.
I chose 3 because
Mm-hmm. Oh, I'm not choosing any answer to be correct, too, but I'm just sensitizing ourselves.
I read that with PEA on the
Your answer
cardiac
first
monitor.
again.
C,
Okay.
on the cardiac monitor, the electrical rhythm is normal, but they don't have pulse. Okay, so after doing the CPR, what I will do is I'll assess the patient first and see. I'll not go ahead with any intervention. I'll have to assess. So I'll find out if the patient or the client has. Oh, I didn't read. Oh, okay.
You see?
Yeah, I didn't read it
You
well.
see?
Okay.
You see? Read the question.
I
I mean, the
believe
option
I'll
have to be
go
very
in
good
for D.
before you start choosing your answer.
Bosim, I'll go in for D.
Why D? I'm interested in your explanation.
Yeah, I think 15 minutes for CPR is too early to quit. Maybe if I
Yeah.
continue, the patient might survive.
So you see, actually, questions on the NCLEX are not so difficult, just a bit tricky. Okay. That is why I was
Yes.
asking you to pay
Yeah.
attention to the
D.
words over here. You see, PEA is not asystole. Okay. You have pulseless electrical activity. So you let us take it as it says, how the English has been constructed. A client with severe hypothermia was found unresponsive. The cardiac monitor shows pulseless electrical activity. Now, after 15 minutes of performing CPR, so it means after we found patients showing this pulseless electrical activity, we started CPR and we've now performed it for 15 minutes. Okay. Now the question is asking us, which should be our next action? So you find a patient with hypothermia and PE, you perform CPR for 15 minutes. Then after, you know the time of death. And after you discuss options for care with family, or you go and find out whether client has a living will.
No, you do
No,
you
you even
continue with the
started the
CPR.
CPR already. No, you can't continue.
You can continue.
You can continue.
You can continue.
Someone said you can't continue. I'm interested. Why can't you continue?
So how long are you going to resuscitate?
So that is a good question. Please, we don't have, you see, we have rules for this thing. It's very dicey. I mean, let me say interesting. Okay. When you perform CPR, like it is not a law that you should stop within 15 minutes, you should stop within 30 minutes, you should stop within 1 hour, or you should stop within 2 hours. We have rules. Some of the rules that I remember, and it's very important, especially to related to when you can call everything off, is when there's evidence enough that all the team members are exhausted and can't do any more CPR. That is one of them. Okay, when there's enough evidence that every member of the team performed the resuscitation are tired or are exhausted, completely exhausted, and can't continue. That is one very bright option I remember. So those of us who have been doing CPR for 30 minutes, 15 minutes, and we think there's a time for every CPR. Sometimes you can do CPR for someone for about 45 minutes, 1 hour, and the person will come back. The person will later recover and walk. Okay, so let's just take note of that part. So for our sister who asked, how long are you going to do? 15 minutes, you've just begun. We'll do proper CPR somewhere one day. Okay. All right, any other question? So I think our answer is C. You can read the rationale briefly.
Is it C or D?
It's D rather. You continue CPR.
Yeah.
I got it right.
So you see, you just read the rationale very well. I think it's even throw more light on that. Have you learned something?
We are still reading it, boss. Please.
Okay. I think we are okay now, right?
Yes, please.
Yes, please. Thank you.
So let us take note of it very, very, very well. It's very important. Okay, so this will be our next one. I think because of our time, let us end it here, okay, and continue another time.